Good morning, good afternoon, good evening, everyone. Welcome to our recap session. We are so excited to have our three females here, women in medicine. We have Yaz, we have Amrish, we have Tansu, and this is one of our recent initiatives where we have been every single month, the first Tuesday of the week, we have been had three of our members in our CP Solvers Academy team, three of our beautiful members that choose a case that has been presented in the past month, and they discuss the case in terms of presenting the teaching points and summarizing everything for us. So today we also have Tansu's cat joining us in the background. And so we will have Yaz, Amish, and Tansu, please introduce yourselves and tell us a little bit about yourself. What do you like to do in your free time outside of medicine?
All right, I'll go first. Thank you for the lovely introduction, Aisha. And this is my first teaching point recap VMR, and I'm really excited that I have the opportunity to present one of my own cases that I was able to present earlier last month. I'm Umbish Dino, and I've been a member of the CP Solvers team, and I am really excited to be presenting my cases with all you beautiful girls. And outside of work, I have cats. I like to sing. And Tansu, I see your cat. I also have two cats. So I'm a pet mom as well. And I forgot to mention I'm an international medical graduate from Pakistan, and I'm applying for my internal medicine residency this year.
Hello everyone. My name is Tansu. I'm an international medical graduate from Istanbul, Turkey, currently located in New York. I joined the CP Solvers Academy in August, and this is also my first teaching point recap. Outside of medicine, I like doing Lindy Hop, which is a partnered swing dance, and it originated in New York actually. So I'm so happy to be here doing Lindy Hop day and night.
Hello, everyone. I'm Jasmine. I am a Mexican medical graduate, and outside of medicine, I like plants, as you can see. So, yeah, I'm very happy to be with you all, and Tansu and Amrish. And Aisha, you have to also introduce yourself.
I forgot to introduce myself. My name is Aisha, and I'm one of the CP Solvers team members. I joined the group, the beautiful team, in March, and I've loved every single case that's been presented. And I'm also an IMG from the Middle East, and yeah, I'm so excited to get this started. And Ambish, would you like to go first?
Sure. Thank you, Aisha. I'm going to share my screen with you guys. Okay, can you see that?
Yes, you're good to go.
All right. So the topic today is we're going to unravel a lung mystery with me. And like I said earlier on, this is a case that I was lucky enough to present to Dr. Ravi Geha and Amanda Barreto. And Mariana, I want to give a shout out to you as well. You did a beautiful job on the teaching points. And so I just wanted to recap this case because there was so much learning involved in this case. And I call it a mystery because there was a lot going on with the patient, and we had two diagnoses for the patient. So first of all, I'm going to talk a little bit about the problem representation because for those of you who weren't able to see this case, I'd like you to have a background history of what was going on. But those of you who did attend might remember that I referred to my patient as Mr. Tywin Lannister, just to add a little bit of a personal touch. So Mr. Lannister, who is a 79-year-old male, presented to our ED with a past medical history of rheumatoid arthritis-related interstitial lung disease. And he was on adalimumab, which is a TNF alpha inhibitor, goes by the name of Humira. So this shows that he was immunocompromised. And he presented with a 1 week history of shortness of breath. And that had been worsening because he already had ongoing shortness of breath, accompanied with a productive cough as well as fever. Now, Mr. Lannister was hypoxic in the ED, and his oxygen saturation was 86% on room air. We did his imaging, and it showed bilateral patchy opacities and focal right lower lung lobe consolidations. His blood work indicated pancytopenia as well as a high LDH. So that was a little bit about what was going on with Mr. Lannister, and we had two diagnoses for him. The first one was an incidental, and we found it on the high resolution CT that we were able to do for him. And this was cryptogenic organizing pneumonia. And this is also going to be my main topic of focus today because it's a rare entity. And for me, this was my first time, seeing a case of cryptogenic organizing pneumonia. And I know that a lot of you are IMGs and starting out in your residencies. And, I hope that the next time that you guys come across a cryptogenic organizing pneumonia, you guys are able to, crack it open and kind of go about it, in a much easier way than I was able to. So the second diagnosis, the final one that was life-threatening, and, unfortunately, the patient could not make it, was pneumocystis jirovecii pneumonia. Moving on, what is cryptogenic organizing pneumonia? Now, I'm going to teach you guys the way I like to teach myself, and I love teaching. So this is how I go about these new entities and all these terms, scientific terms. So what I do is I break them down and I try to kind of understand the underlying meaning of each term so that when I hear the term, it's not just some words, it has meaning. So the first term is cryptogenic, right? So what does cryptogenic means? It means uncertain, idiopathic, and that is the main cause or etiology of cryptogenic organizing pneumonia. We do have secondary organizing pneumonias, but this is a case of the primary cryptogenic organizing idiopathic pneumonia. So also keep in mind, cryptogenic organizing pneumonia is an interstitial pneumonia, right? So when you do PFTs for these patients, you're going to see a restrictive pattern. The second term is organizing, and that kind of refers to the alveolar organization that happens due to the inflammatory process, right? So when there's inflammation, there's recruitment of fibroblasts, myofibroblasts, and then they proliferate. And what ends up happening is they're going to start obliterating the alveolar lumen, which is why we call it organizing. Finally, we call it a pneumonia, but remember, this is a non-infectious state. It is an inflammatory, reversible, fibroproliferative disease. So it is not infectious, hence there is no use of antibiotics here, which is why it is responsive to glucocorticoids. And that is what we did start in this patient. And it usually helps, and the patient can go back to, having normal lungs. Now, what does a typical case of cryptogenic organizing pneumonia look like? So these patients usually present with a persistent cough, shortness of breath or dyspnea, like Mr. Lannister did have, fevers. Again, our patient had it. So what I found really interesting was that Mr. Lannister was a very classic case of cryptogenic organizing pneumonia. But what I also find interesting is that in real life, you don't just see the classic picture, you see a mess of symptoms. You see this whole, sort of like, this, I don't know the right term, but you see so many things going on. It's hard to kind of pick onto the most significant and the most pertinent details and kind of align your thought processes towards the diagnosis. Because if you look at the screen, persistent cough could happen with anything. It could be an allergic cough. Shortness of breath could be anything. This patient already had ILD, right? So for what I could think of, it could probably be due to the ILD, but it was a lot of things going on. So fever, again, it is a vague symptom. Malaise, vague. But this is what a typical case of cryptogenic organizing pneumonia would look like. A very important thing to keep in mind is that it is a subacute to acute state. It is not chronic fibrosing state. So this is going to be a short duration history. And our patient had 1 week of shortness of breath, right? So these patients can go on from weeks to months. It'll never be a 1-year history of persistent cough and shortness of breath and all of that. And then on the lung examination, you will most likely be able to appreciate inspiratory crackles. Now, now let's relate it to Mr. Lannister's clinical picture. He had shortness of breath for a week, cough, and a fever. The lung auscultation revealed crackles all over the lung fields. So kind of fits that picture. The first thing you do in the ED for such a patient would be an X-ray. We did that. And now here are some of the findings that I've jotted down that you will most likely see in a case of cryptogenic organizing pneumonia. And again, these are very vague findings. It is a spectrum of findings that can mean anything. So I'm not going to get into the depths of each and every one of them, but I'm just going to point out some of the, the ones that usually catch my eye at my level of, practice. So first of all, bilateral. Whenever you see bilateral findings that you can appreciate in Mr. Lannister's X-ray, you should think of a systemic process rather than a localized one, right? And I want you to think of conditions like pneumocystis jirovecii, viral pneumonias, interstitial lung diseases, right? Then it could be patchy versus diffuse. And honestly, for me, it is both patchy and diffuse, right? Then something that catches my eye, and I want you guys to sort of start typing out in the chat, what comes to your mind when you think of consolidative versus ground glass opacities? And that is something that kind of does pick my attention as well when I look at an X-ray. Then it could be peripheral. Mostly people with cryptogenic organizing pneumonia do have peripherally located, pathology, right? So you can see this is very peripherally organized, right? Central areas are kind of spared. Then there's the pattern could be irregular, linear versus nodular. And in Mr. Lannister's X-ray, you can appreciate bilateral, patchy opacities and diffuse interstitial infiltrates. All right, so I'm seeing the chat right now, and I see that a lot of you already know what I'm about to say. So when you think of consolidative, and I see, Seema, you've actually broken it down perfectly for me, and this is something that I wanted to bring up, but if you read or comment, I don't even need to go into the details of that. So when you see the term consolidative, you're thinking of a localized process, a pneumonia, right? And then you can see, depending on the distribution of the consolidation, whether it was, an aspiration pneumonia, whether it was something else, right? So consolidation usually should make you think of a localized pneumonia, right? Infectious pneumonia. And then when you think of ground glass opacities, it is usually filling of the air spaces, partial filling. Consolidation is complete occlusion, as Seema also mentioned. And then ground glass opacities are partial filling of the air spaces, right? Which would then cause interstitial thickening. And when you see this term, or when you see ground glass opacity, I want you to think of three things: PJP, organizing pneumonias, and viral pneumonias. So our patient actually had two of those entities, PJP as well as organizing pneumonias. And then I wanted to bring something up, that when you see an X-ray, it usually does not help you diagnose. It usually just helps you align your thought process and move on to the next modality in a patient that is so complicated. So for our patient, the next move was to kind of do the labs, and the labs are again not to diagnose, but to rule out, right? So we went and did the sputum gram stain to see whether it was a bacterial pneumonia. We did the cultures. We started our patient. We actually thought of Mr. Lannister as a case of community-acquired pneumonia. He was immunocompromised, and we thought that, he probably had community-acquired pneumonia. And then what happens is we usually start these patients on antibiotics for pneumonia, right? Macrolides and the regular ones. We did that. He wasn't responding. So we put him on a broader spectrum. Now, what I love about the practice in US is that it is very evidence-based. It is very focused on, labs and, all those modalities to kind of make sure that you're not causing any harm. You're not using anything extra that the patient does not need. So in our patient, we went ahead and we did the MRSA NIRS, which came out to be negative. So we discontinued the VAC, right? Then we did the urinary studies for pneumococcal, Legionella antigens, strep pneumo being the most common cause of community-acquired pneumonia. So we're just ruling out here. HIV, something very common, you want to rule it out to make sure that it is not an acute HIV. And lastly, I've highlighted this beta-D-glucan here. Why did I do that? Because in our case, our patient was deteriorating constantly. Our patient was not responding to the antibiotics. So in such a case, the next step is to look for a fungal pneumonia. So beta-D-glucan is actually a component of the fungal cell wall. And we check that to see if it's a fungal pneumonia. And when you think of fungal pneumonias, I want you guys to think of three things: Aspergillus, pneumocystis, and Candida, right? So we did all of that, and eventually we wanted to look further into, what was going on in the lungs. So we did the high-resolution CT. The high-resolution CT that you see on your screen right now is from the actual patient, and I have permission to share it. I've also shared the actual impression that you guys can read underneath it. But at this point is when we diagnosed Mr. Lannister with cryptogenic organizing pneumonia, right? So now again, in cryptogenic organizing pneumonia, you can have diverse radiographic patterns. You can have patchy air space consolidation, which you can appreciate, you can see ground glass opacities all over this. You can see nodular opacities, you can see consolidation and bronchial wall thickening with dilation. You can see these dilations, right? Because it's a chronic process. So moving on, definitive diagnosis. If you know you're suspecting cryptogenic organizing pneumonia, you want to do a bronchoscopy and take a bronchoalveolar lavage, you want to do a biopsy, you want to do a definitive lung biopsy. But with Mr. Lannister, he was deteriorating so much that we actually had to put him on a high flow nasal cannula. So he was too sick to undergo a bronchoscopy. So we made a preemptive diagnosis of cryptogenic organizing pneumonia, and we started him on steroids. And by this time, we already knew this is cryptogenic, but we also knew that something else is wrong, right? But in an ideal world, you would want to do a lung biopsy. And what would you see on the lung biopsy is something known as the Masson bodies, right? And I extracted this image for you guys from Wikimedia. And you can appreciate that this here is an alveolar lumen, which is now completely occluded. It is obliterated due to the organization, due to the inflammation. And on the side, I also wanted you guys to kind of be able to appreciate that this is a vessel. You can see blood inside it. So this is the blood vessel. This is the alveolus, which actually is supposed to be very clear. It's supposed to be patent, but it's not. So at this point, I'm going to conclude my journey of cryptogenic organizing pneumonia, and I'm going to quickly move on and give you guys a quick overview of the final diagnosis, which is a very life-threatening condition if left untreated. And this is what mainly kind of worsened our patient's condition very quickly. And this was pneumocystis jirovecii pneumonia, which goes by the name of PJP or PCP. And while I summarize this case, I want you guys to start typing out in the chat, what is that exact count where you give prophylaxis for PJP, and how do you treat PJP? And I'm already positive all of you know it, but I want to see what goes on in the chat. And while you guys type, I'm going to share my thoughts on PJP. So PJP, first of all, is an opportunistic infection, and our patient is the perfect picture for that. He was immunocompromised. Patients with HIV are at a higher risk, and I wanted to know the CD4 counts. And I can already see in the chats, all of you have simultaneously mentioned CD4 counts below 200, and I love that. And that is exactly what it is. CD4 counts below 200 is a very high risk for a patient to develop PJP. So you want to start them on prophylaxis. And now I can see you guys typing out, how do we give prophylaxis and how do we treat this patient? But I'm going to come on to that in a little while. So nearly all patients, when they present with PJP, are hypoxemic. An important clue to keep in mind. Our patient was on 86% saturation, right? So that was a big clue. And then an association with rheumatological disease. This was very interesting. I went through UpToDate. I went through some articles. Very interesting that PJP as well as cryptogenic organizing pneumonia both have an association with rheumatological diseases, right? And that was very intriguing for me to know, because this makes this a perfect case of a rheumatological disease, and that's setting up a stage for cryptogenic organizing pneumonia as well as PJP. Then again, the labs that we run are usually the most rapid and least invasive. One is microscopy with staining of induced sputum, bronchoscopy with bronchoalveolar lavage, which we were unable to do for our patient. And then the most, I think, specific test would be a PCR, could be for the induced sputum, for a BAL, for blood, or the nasopharyngeal aspirates. Lastly, a very important thing that I picked on was that people who have HIV and people who don't have HIV present differently when it comes to PJP. So with HIV, the course is indolent. And earlier on in my problem representation, I highlighted how the patient had high LDH. So if a patient has HIV, has a high LDH, you want to think of PJP. Very strong indicator. But nonetheless, an elevated LDH in the setting of pulmonary infiltrates without any apparent cause should raise suspicion for PJP pneumonia. And then a patient without HIV, which is our patient, will present with fulminant respiratory failure, which is what we experienced, fever and cough, which is what we saw. And moving back to the chat, guys, I'm absolutely impressed by all of you here. We do treat PJP with Bactrim, which is TMP-SMX. And another important thing to keep in mind is that steroids also have a role in PJP. And that concludes my recap of this case. And I'm going to quickly go over the take-home points and do the spaced repetition. So what did we learn today? Cryptogenic organizing pneumonia is an idiopathic interstitial pneumonia that tends to mimic community-acquired pneumonia. It is a fibroproliferative process. It tends to present acutely or subacutely. It is non-infectious, no use of antibiotics. It is reversible, responds to glucocorticoids, and it should be suspected in immunocompromised patients. Other than that, it has an association with connective tissue diseases like rheumatoid arthritis. Very interesting finding. And finally, you want to diagnose it with a high resolution CT, bronchoscopy, and biopsy, depending on the state of your patient. And here we are, we have our references. Excuse me. I created this presentation using Canva. Thanks to Yaz. This morning, Aisha was going over my case and my presentation looked horrible. And I was very scared to present it. But then I saw Yaz's presentation and I was mind blown. And I discovered Canva, and I love how we learned so much in this community. And then I changed my presentation and kind of made it a little bit more presentable. So thank you, Yaz, and thank you, Aisha, for taking the time to go over my presentation and to help me make it more interesting. And I hope that you guys learned something today. I absolutely had a ball teaching, and this quote really catches my eye every time I'm in the VMRs and I'm looking at the whiteboard. One life, so many dreams. I feel like a lot of us can relate to it. And here we have the CP Solvers Twitter handle and mine. If you have any questions, please feel free to ask them in the chat. And I'm going to hand over the mic to Aisha once again.
Thank you so much, Amish. That was amazing. That was masterful teaching. Honestly, I know you said COP pneumonia is non-infectious, but I'll tell you, your enthusiasm, your passion for teaching is so infectious. We could feel it all the way from the other side of the world. So thank you so much I know it's very late on the other side of the world. I appreciate you staying up. You have so many mom duties. We appreciate you taking your time, and your way of educating us is just amazing. And I don't know if you noticed, by the way, we have an audience of CP solvers, but we also had two extra members from Tansu's background. You got two extra cats listening to everything that you were saying as well. So thank you so much. And Tansu, you're next. Oh, and your cat's joining us again. Tansu, the floor is all yours.
Thank you so much. My cats absolutely loved Ambitious presentation, and now they want to come closer to the screen. But now I will present my screen. All right. Can you guys see my screen?
Yes.
Awesome. All right, so I will be recapping the case that was presented by Anmol and discussed by Rabi and Maria, and it was a case of infective endocarditis. So let's go. First of all, let's define what infective endocarditis is. It's the infection and inflammation of the endocardium, which is the innermost layer of the heart that surrounds the chambers and the valves. We really care about the valves here, and this is because of two reasons. The first one is valves are really mobile, so anything that's friable and infected like a thrombus can easily flick off and embolize through the arterial system to any of the organs. And we also care about valves because they are not very well vascularized. So the immune response may not be able to reach the valves well, and the infection cannot be fought off. That's why we care about the valves. And infective endocarditis has really high mortality and morbidity, so we need to diagnose and treat it fast. Oops. All right, so I have a question for the audience. Which of the following clinical presentations would most strongly suggest infective endocarditis? A 31-year-old man with subacute abdominal pain and weight loss. B, 23-year-old male with headache, sudden onset unilateral amaurosis. C, 31-year-old male with right upper quadrant abdominal pain and non-bloody diarrhea. D, a 48-year-old male with new onset right-sided weakness. So please put your thoughts in the chat and I can see your answers. Yes, a lot of people think it's D and we have some Bs. Perfect. Very nice, guys. So how about I give you one more piece of information and say that all of these patients had also fever in addition to their chief complaints. So how would that affect your diagnostic reasoning? Exactly. So it would point you towards, in all cases, towards infective endocarditis, because fever is actually the most common finding in many patients that present, that get the final diagnosis of infective endocarditis. In a large multi-centered prospective cohort study, fever was seen in 95% of the patients. So it's a very, very common finding. And we'll be discussing option D today, the patient right here with who is a 48-year-old male with new onset right-sided weakness and fever. So let's revisit our problem representation for those of us who haven't seen the case when it was presented real time. So if we had a 48-year-old man with recent dengue infection and thrombocytopenia, presented with sudden onset right-sided weakness, high-grade fever, and altered mental status. During hospitalization, he had respiratory failure and found to have brain and spleen infarcts and acute focal nephritis on imaging. His echo revealed small vegetations on his valves with a negative blood culture. So when we look at this patient's labs and physical exam, we see that his clinical status, vitals and lab results resembled an infectious inflammatory process. However, notably, he didn't have any murmurs and his blood cultures were negative. So when we have a case of acute ischemic stroke resembling picture, like we have here with a patient who has right-sided weakness, we have to manage before we diagnose. So how do we manage such patients? First of all, we have to know what was the last known normal, and then we have to medically stabilize the patient if they're not medically stable. Then we have to reverse the reversible causes, and these can be sugar, and if we are suspecting any opioid use, that could be the opioid. And then we have to get a non-contrast head CT to rule out hemorrhagic stroke. And then we can finally get started on uncovering the pathophysiologic basis of the patient's neurologic symptoms. And the issue of IV thrombolytic therapy is something that we have to pay close attention and give consideration to, because it can be a beneficial therapy in regular good old thrombus, but in the case of infective endocarditis, because of the potential presence of mycotic aneurysms, giving IV thrombolytic therapy can be detrimental to the patient. All right. So let's define the problem together. And we love doing this in CP solvers because that's the cornerstone of our diagnosis. So our patient had a focal finding of right-sided weakness. And we later found out from UNMOL that our patient also had altered mental status. And we know the causes of altered mental status. We have our missed mnemonic, which beautifully coins the most common causes of altered mental status. And when we open our mnemonic, we see metabolic, infectious, structural, and toxins as the causes of altered mental status. But combining that with the focal neurologic findings, other than the structural causes in the missed mnemonic, none of the other components of missed would cause focal neurologic findings. So we direct our attention to the brain here. And then we later found out that the patient had a hyperacute time course while presenting with these chief complaints. So for hyperacute neurologic syndromes, we have our 3 S's, sugar, seizures, and stroke. And in the previous step, when we were managing the patient, we already ruled out hypoglycemia and seizures with the lack of the post-ictal state and tonic-clonic movements. So we are now directing our attention to stroke and vascular causes. And vessels can be either blocked or they can burst and bleed. So what type of stroke could cause altered mental status with focal neurologic findings? And in that, we think of two types of stroke. First one is hemorrhagic stroke, and the second one is ischemic stroke with multifocal emboli. And then we layer the last finding of fever into the picture. And we have many causes of focal neurologic findings, altered mental status, and fever. But Anmol gave us the subsequent imaging findings in this patient that CT angiography didn't show any atherosclerosis or segmental narrowing in other arteries. So that rules out autoimmune causes. And in the MRI, multifocal infarcts distributed over different territories was seen. And so this directs our attention to a vascular issue, potentially infective endocarditis with embolic stroke. So whenever we have a thrombus, we have to ask three questions. Where did the thrombus come from? What's the nature of the material occluding the vessel? And is there any clues to the nature of the thrombus? So since we know that we have a multifocal embolic stroke, that can be secondary to either a central clot in a bad location, or you have a widespread problem that's unleashing a clot formation everywhere. And in that category, there are couple pathologies that we can think of. For example, APLS, vasculopathies, and vasculitis. But we saw in the CT angiography that our patient didn't have any other problems in such as focal segmental narrowing or atherosclerosis in his other vessels, but he had a multifocal emboli. So we think that we should look at the central apparatus, which is the heart, to examine what's happening to our patient. And then we got the echo results, which showed vegetations on the valves. So infective endocarditis. When we think about what predisposes patients to infective endocarditis, we have two broad categories. The first one is abnormal valves and structural heart defects, and the other one is anything that increases the risk of bacteremia. In our patient, he didn't have any prosthetic valves or previously damaged valves or structural heart defect, and he didn't have an immunocompromising condition in the traditional, usual sense that we always think of. But let's remember dengue here. He had a dengue infection 2 weeks prior to his current presentation. So in our patient, we suspect that dengue predisposed him to having infective endocarditis. All right, so let's visit the microbiology of infective endocarditis. And I'll just make 3 points here. So first of all, there is actually, infective endocarditis can be classified based on the type of affected valve, the side of the heart that the affected valve is, and then based on its chronicity and acuity. And we can basically say that the acute cause is the most virulent causes of infective endocarditis. And in that, there's Staph aureus. And Staph aureus is so virulent that it can even affect the native valves. The patients don't have to have prosthetic valves. And in subacute category, we have many pathogens, but I will direct our attention to culture negative infective endocarditis because this is what our patient had. And for a patient to have infective endocarditis that's culture negative, there are 3 possibilities. First, either the culture should have been positive, but we gave the antibiotics to the patient that turned the culture to negative. Second, the microorganism that's causing the infective endocarditis can be grown in culture, but it's hard to grow, such as the ELAS, so Coxiella, Bartonella, Brucella. And then third, the microorganism can never be culture positive. So what we suspected in our patient's case was he fell in the first category of being culture positive potentially, but since he got antibiotics, his culture came out negative. All right. So when we think about infective endocarditis, the findings that come to mind are usually the board-tested Janeway lesions, Osler nodules, splinter hemorrhages, and all that. But the actual prevalence of all of these findings are 5 to 10%, as opposed to cerebrovascular ischemic complications of infective endocarditis, that is 40%. So that's pretty big, and that's why next time when we see a patient who's febrile, who's presenting with focal neurologic deficits, we should keep infective endocarditis in mind. How do we diagnose infective endocarditis? So as all of you know, we have our modified Duke criteria for the clinical diagnosis of infective endocarditis. I'm not going to go over every single major and minor criteria here, but I will just say that in the major criteria, we try to demonstrate the organism. Either in blood cultures or through echocardiography. And in the minor criteria, we have blood cultures that don't meet the major criteria and some other clinical findings. So we can just keep the framework in mind in such a short, simple way like this. And we get some help from imaging when we diagnose infective endocarditis. So when a patient walks in from the emergency department's door, transesophageal echocardiography may not be readily available. But what's available readily is the transthoracic echocardiography. The sensitivity is a little low, but if we are suspecting infective endocarditis strongly and we get a negative transthoracic echocardiography, we should get a transesophageal echocardiography, which has a higher sensitivity, and specificities of both tests are quite high. All right, my last question before finishing off. So we have a 40-year-old man with a 4-day history of malaise, right-sided weakness, fever, and chills. He's an active IV drug user. His temperature is 40 degrees Celsius. Physical exam shows multiple hyperpigmented lesions on the nail beds and a 4 out of 6 high-pitched decrescendo early diastolic murmur on the left sternal border. On his EKG, we saw a new onset 3rd-degree AV block. Why do we have these ECG changes? So please put your thoughts in the chat. Ashutosh, you are great. You started writing out the answer even before I finished the question. You guys are all very smart. Thank you so much. Exactly. Our patient had a perivalvular abscess, which is a severe complication of infective endocarditis, and it causes conduction abnormalities, including a 3rd-degree AV block. So in a case like that, since complications are often seen in infective endocarditis, when we suspect infective endocarditis in patients, we should refer those patients to centers that have the comprehensive team with cardiologists, cardiovascular surgeon, nephrologist, and neurologist, so that the patient can be well taken care of. And here are my teaching points. So let's quickly recap one more time. Altered mental status, as we saw in our patient, we should think of MIST, metabolic, infectious, structural, and toxic causes of altered mental status. But since our patient had a focal neurologic deficit, that narrowed our thinking to the structural causes. And then we had a hyperacute neurologic syndrome, which should make us remember our 3 S's: sugar, seizure, and stroke. When we have a thrombus, we should ask 3 questions. Where did it come from? What's the nature of the thrombus? And are there any clues to the nature? Patients who are recovering from dengue are at risk for hemophagocytic syndrome and bacterial superinfection, secondary to the temporary suppression of the immune system. It's not a very when we say immunosuppressed it's not one of the things that come to mind immediately, but it should come to mind from now on when we encounter it again. And in culture negative infective endocarditis, this can be because of three reasons: either because of prior antibiotic use that made the culture negative, or the microorganism can be grown in culture, but it's hard to grow. And thirdly, the microorganism can never be culture positive. We should keep in mind that cerebral ischemic events are highly prevalent in patients with infective endocarditis. That makes about 40% of the patient population, and modified Duke criteria has a sensitivity of 80%. That's pretty good, but the sensitivity falls in prosthetic valves and right-sided endocarditis, so it's good to keep in mind. And transesophageal echocardiography is more sensitive, but since it may not be readily available, we can first do transthoracic echocardiography, and then if it's non-diagnostic or negative, but our clinical suspicion is still high, then we should proceed with transesophageal echocardiography. And if we see a new conduction abnormality in a patient with infective endocarditis, we should suspect a perivalvular abscess. Thank you so much for your attention. And here are my references. If you have any questions, please put them in the chat.
Thank you so much, Tansu. You have made such a difficult topic so easy to understand. And I really appreciate how much time you spent into the questions that you had in your presentation. I think they involved all your teaching, and it goes without saying you are such a natural educator, and we can see how much you enjoyed making this presentation, teaching us. So thank you so much, and I have really enjoyed listening to your prior teaching points and all the prior VMRs, and you have just become a natural educator. And I don't know if you could tell, but the audience was really engaged and they enjoyed your questions. And if any of the audience members have any questions for any of the members, please put them in the chat, or you can send them to our team members later on, if you remember. And we have our micro ID queen. Please help us and help us resolve our microphobia. And the floor is all yours, yes?
Thank you so much. That's very kind of you, honestly. I am very honored to be considered like ID queen. So I'm going to start my presentation. I chose Dr. Jazz's case of West Nile virus. And the discussants, as usual, amazing, Ravi and Prof. Res. Now, in our case presentation, everything started with a 65-year-old man with 5 weeks of diarrhea, along with 2 weeks of memory impairment. The patient had evaluated for diarrhea patient, for C. diff negative, Giardia negative. The symptoms were not affected by food intake. And about his neuro symptoms, he had a short-term memory loss. He didn't remember like the significant conversation. He stopped speaking midway sentences. And he also had this past medical history of a polyarthralgia 7 months ago, positive for HLA-27. So this person had a lot of things going on. That's what made this case so complicated to determine which could be your differential diagnosis and how to tackle it. In his past medical history, he had pulmonary and hepatic sarcoidosis, OSA, DM, GERD. He was taking hydroxychloroquine, mycophenolate, and other drugs. On his social history, he didn't have a significant exposure, although he mentioned that in his work he used to travel, even if he hadn't for 6 months prior. Now, our key points while tackling this case were thrombocytopenia. This was an MRI negative case, and that the bilateral weakness that progressed to instability and affected ambulation was the main reason of why this patient sought care. Now, we were thinking, this person had thrombocytopenia, so it prompted Prof. Res to think, should I be looking for a peripheral destruction? Should I be looking for splenic infarction, or even into the bone marrow? And the main step could have been CT abdomen. Then the question remained, what was the exact problem that we were solving? It was even framed as an MRI negative, CT enterography negative, CNS, GI, rheumatic peripheral neuropathic processes. And as you can see, we had many chief complaints here, and all of them had very varied differential diagnosis. Now, the first step that Dr. Rabi mentioned was that in a patient with a neurologic presentation, we have to localize central versus peripheral. First, what are the rules of peripheral neuropathy? Is it slowly progressive? Is it sensory predominant? Is it symmetric? And if you would answer no to any of these rules, there is not likely a peripheral neuropathy. In this patient, this was neither slowly progressive nor sensory predominant. So we could start driving towards the bilateral lower extremity symptoms being caused by a lesion in the spinal cord or in a bilateral brain territory, such as the ACA. Now, trying to understand the case and trying to make a narrower differential diagnosis, our first localization, the acute neuropathic disorders versus acute spinal cord conditions. And we can use it. We can use a reflex examination, which is typically used to distinguish between these both two. If neuropathic conditions normally lead to a loss of reflex, while the opposite is seen with spinal injury. We can also see that the extremity weakness can be seen in both. And this person, if we really see what was the main issue, it was that he had bilateral lower extremities paresthesis and weakness, fatigue. His reflexes were diminished as well as the touch, so slightly. And the confounders, we could take them as diarrhea and thrombocytopenia, as well as his past medical history of polyarthralgia. So trying to take away some of the variables. Now, the second step, what do? In his lumbar puncture, we found elevated protein, normal glucose, cell count clear and colorless, and elevated nucleated cells. His gram stain was negative. IgG was normal for Cryptococcus, for CMV, for enterovirus, for E. coli, etc. All of them were negative. The MRI was normal. So now the diagnosis looked way different. We were thinking, could it be a prion disease? Could it be a Whipple's disease, epidural abscess, or cauda equina, or the demyelinated process that's MRI negative, or even a deficiency? But at the end, we found out that IgM and IgG for West Nile virus was positive. What is the difference, or what is the difficulty with this virus? Well, before diving a little bit more, let's start saying that flaviviruses are a very, very broad family, wide family. It can be mosquito-borne or tick-borne. In the mosquito-borne, we have dengue, Zika, West Nile virus, and for every topical doctor that might be listening right now, you might know that trying to differentiate between all of them, it's quite difficult. Why? Well, because 80% of patients are asymptomatic, 20% will develop fever, diarrhea, arthralgia, or rash, like a flu-like illness. So it's very specific. Only 1% will develop neuroinvasive disease, and 1 in 10 of these patients inside of the 1% will die. So when we have a neuroinvasive West Nile virus, it's very important to find out the diagnosis as soon as possible to start supportive care. Routine labs may reveal leukocytosis and specific findings, and a hyponatremia may be seen when CNS is involved. Although, as you might have seen, this patient had nothing. Everything was unremarkable on his labs. Now, how is it neuroinvasive? These flaviviruses can affect the subcortical nuclei, the substantia nigra and thalamus, the anterior horn neurons, all of these affecting motor areas. And the mechanism for viral CNS entry is not very well understood, but it's believed that the macrophages can cross directly the blood-brain barrier. And once in the CNS, the virus primarily induces inflammation, and subsequent loss of neurons within the spinal cord and the brainstem gray matter. That's why we have this picture of in three main forms: meningitis, encephalitis, and acute flaccid paralysis. It typically presents in the first 24 to 48 hours of the illness with acute onset of limb weakness and hypo or areflexia. But again, sensory changes may be seen. Weakness is usually asymmetric and may involve the facial nerve. Although this is not completely seen in every case, as you have noticed with this patient. What do we expect on workup? Literally only protein and leukocytosis. So that's the main thing you have to think about. The IgM is present in this CSF by day 7 in 95% of patients. And in MRI, you can sometimes see some leptomeningeal enhancement, although only 20 to 70% of patients will exhibit this imaging abnormalities. So a final diagnosis will be done by PCR, cell culture, or a specific IgG and IgM antibodies in serum or CSF. You can even use the ELISA, but it's preferred, the PCR is preferred. And you can find this IgM antibody captured suddenly with ELISA within 8 days of illness onset for over a year. Now, the teaching points of this case: how did we arrive to knowing that it was West Nile virus? Something that's very important to mention is that in the United States, every single state since 2021 has presented a native West Nile virus case. So really everybody's exposed. When asked to the patient mentioned that he used to walk the dog, something that everybody does in their normal lives. And you can be exposed. So don't forget to use repellent and use crinoline on your windows if you're going to open them to avoid the entrance of mosquitoes to your house. So remember, West Nile virus can be asymptomatic mostly. Only 20% of the people will present a flu-like illness, and less than 1% will develop severe West Nile virus neuroinvasive disease. And 1 in 10 of the patients will die or develop really bad sequelae like quadriplegia. The diagnostic workup includes the CSF analysis, MRI, and electrodiagnosis evaluation in some of the cases, but this is confirmed by reverse transcription polymerase chain reaction. Always consider neuroinvasive West Nile virus disease on a patient with acute flaccid paralysis, and LP with lymphocytosis that could be MRI negative, at least here in the US. So here are the reference for anybody who can be interested in reading a little bit more. And that will be it. Thank you so much for all of your attention. I really like having this session with all of you amazing women.
Thank you so much, Yaz. I'm just going to say I'm amazed but not surprised at how well you constructed your presentation, and you covered West Nile virus so well. Now I know if I ever need to review it, I have your presentation to go back to. Thank you so much. And thank you all for attending our session today. We will see you in our next VMR. If you have any questions or concerns, you can email us. And if you have a case to present that you would like to present on our daily VMRs, feel free to email us on our website. And yeah, I hope you all have a great long weekend, and we'll see you next time. Bye. Thank you, girls. Bye.